Good morning, everyone. We are going to jump in because we have a full packed 90 minutes for you all today. And we're so excited to be hosted by the Music and Dementia Research Network to talk about our webinar on global perspectives on music therapy and elevating older persons. The four of us as music therapists, along with one other music therapist who couldn't be present with us today, connected a few years ago for World Congress in Canada. And so we've been so excited to continue our partnership. We're getting ready to get our workshop proposals in for the conference in Italy next year. And we just hope we're so grateful for y'all being present with us today to learn more about what we do in our work and how we take a global perspective and really centering identity for older adults and how wide that range can be. So I'm going to kick us off. Everyone is going to introduce themselves as they get to their portion. My name is Melita Belgrave. I'm part of the Research Dementia Network. I'm an associate professor at Arizona State University in the desert or the oven, as I like to call it. And I love getting to work with older adults across the span from well older adults to intergenerational settings to individuals with dementia and individuals at end of life. So I'm going to kick us off and be talking a little bit about some of the theoretical frameworks that I like to use when working with older adults. I really feel like having a good theoretical framework really helps ground you in your clinical practice and what you're doing in your clinical decision making. And it allows us, when we start using ones that focus on identity, it allows us to think about the intersectionality of who an older adult is and all the pieces of them that make up who they are, instead of just thinking, oh, their age is the thing, or the diagnosis is the thing that's going to lead to my clinical foundations. So I'm going to have us go on to the next slide, Lindsay. And I have three frameworks that are there, but I want us to spend some time delving right into the Pamela Hayes addressing framework. So this screenshot is taken from a book written by Pamela Hayes. The addressing acronym stands for those different cultural characteristics that are on the left side of the table there. So we have age and generational influences. So it has the cultural characteristic. Then the next column is who is seen as having the power in US. So this is for US. For other countries, it might be different. And then the column over to the right is the less power. So the people who don't have as much agency or power in those sections. So for this first part, I want us just to look at the table and look through on our age and generational influences, developmental disability, disability acquired later in life, religion and spiritual orientation, ethnicity and race identity, socioeconomic status, sexual orientation, indigenous heritage, national origin, and gender. And you don't have to put it in the question and answer for us, but I do want you to think about when you think about the musical choice, how you are going to frame your interventions, how you ask for participation. I want you to think about which of these categories of cultural characteristics or identities do you think about when planning your session for older adults, and especially for those with dementia, and thinking about what are ways that you might expand that, right? And then I have a couple questions off to the side or some prompts for you to think about. And we're going to start with the intersectionality example that's on the top. And so for this one, I think about roles when we think about like, let's say we're doing an intervention with instrument playing, or we're doing an intervention that has some leadership experiences. Like I'm going to ask Mrs. Jones to do something, right? Going a little further than just saying, I'm going to ask whoever's in the room, thinking about these questions and these prompts. What does an older adult who identifies as female in a specific religion, right? That's going to be the cultural characteristic that this person identifies with. What do they believe about being a musical leader in a group? And how might that affect how you engage her in instrument playing and group process, right? And just thinking off the top of your head, you might be able to think of different religious practices where females are elevated in practice to be in leadership roles, and maybe they are not, right? But thinking about if this is this older person's identity that they really lean into themselves, how we can accidentally offend or accidentally not understand that their lack of participation is disinterest. It might just be related to how they view themselves. Another prompt and example that I wanted us to think about is this national heritage example. A lot of times when we're thinking about music preference for older adults, we're thinking about where are they from, where did they spend their younger years, and some other questions to go along with those prompts is there a history of migration for your clients? And what age was that client when they migrated? And then some of the ones that I like that gets a little deeper, was it proactive or reactive? Was it their choice? What role did music play in their lives pre and post migration? I remember always being struck by a research article that talked about working with older adults in later life in hospice care and assuming that the music of their past was something that they wanted to listen to. And this researcher finding that, there was an older adult with a migration history that was reactive and actually kind of harmful for that person. They did not want to access music from their childhood. And that when they finally became open to it, it was a lot of work that they had to do in that container around that music. So just some things to start thinking about. Again, this is the Addressing Framework by Pamela Hayes. I really enjoy it. The table can be found online for free. You don't have to buy her textbook, but her books are also really, really amazing. And we're going to go on to the next slide and then talk about how I use this then in my practice. So when I'm thinking about using music from other cultures and other spaces, sometimes I actually can't make that happen on just my guitar or just piano. So I use a lot of recorded music. And these are just a couple of the ways I do it. One, finding original recordings and videos, not being afraid to pull up YouTube and Spotify during a session and doing some passive and active interventions around that. I also really enjoy using TuneIn app or something similar. I started using this app. I remember having a session that I was having with an older adult in a hospital. And he was from another country. He served in the army. He traveled the world. He was talking so much about his world travels and what he loved. And I pulled up this app and we were able to listen to radio stations from all these different places that he lived. And it was such a beautiful gift to give to him as well as his wife. When I left the session, I got an email later from the wife saying that they continued to use the app to do a musical journey and exploration. And when you're in a hospital, you don't really get to control a lot, right? So being able to use music to control leaving and finding some sort of exit and joy. And then I also will listen to the music and find elements of the music to develop my own music tracks around, right? And then using those tracks to do improvisation or songwriting interventions. And so I was doing some interventions around the music of North Africa when I was doing a program. And I was trying to think of ways to amplify that music, and it was not through using my guitar. So as we go on to the next slides, I'm going to show you how I used it in a songwriting experience. And one of the things that I have found to be the best gift on working with different cultures of music is actually connecting with ethnomusicologists. I have a colleague who is always able to point me in realistic information. There's so much information out there. So how do you find things that are accurate? How do you find low-hanging fruit on how to access music? And so when we were exploring, we were doing some co-treating with music therapists and musicologists in museums. And we were exploring music of North Africa and West Africa. And she was talking a lot about the style of desert blues. And so we're going to listen to a little bit of it. But my prompts on the screen talks about the instrumentation that you'll hear, the sounds that you hear, and then we'll go into how I use this song as an inspiration for creating an intervention. So Lindsay, if you'll go ahead and play a bit of the track for us.
Bedevele kokoina he amude ai tepe Londona ai tepe Londo he ai tepe Londe koina he bedevele ko he dorma mudokona bende fele Il faut quoi, mon frère? J'ai fait comme des Poche Mayet. Poche Mayet. J'ai fait comme des
And um, I'll go to the next slide. Will be great for me to talk about. So you got to hear a bit of that. And one of the things that I know for me, I get excited about jumping into other cultural music because one, I get to learn, right? And two, I get to have my creativity. And so when I was thinking with this song, I decided, I'm going to do a songwriting intervention. And I decided to take elements of that music and create my own music track. So for mine, my musical style, I made it a little faster. I used guitar, I used rhythm and percussion from Northern Africa, things that were elements of the song. For the songwriting intervention, I used it to explore our culture and traditions. I think I was using this intervention around different holiday times. And so then I gave them an example. I wrote my lyrics first and then left space for fill in the blanks later. But my example was Belizean Christmas traditions, right? My family's from Belize. When I spend Christmas with my family, whether it's stateside or we are in Belize, there's always a lot of music, there's always a lot of singing, and there's also a lot of food and drinking. Those are the things that I can remember from childhood through today that anchor Christmas in my family. And so the songwriting prompts that I gave the older adults was, what do you like to do during the holidays? And what do you eat or drink during the holidays? And then we put it into the song. So again, being able to just recreate this live on my guitar, not a thing, right? So I made a track in GarageBand. I wrote some quick lyrics. I wrote a quick melody. And then as the track goes on, there's spaces where we can add the older adults' words into the lyrics. So we'll have Lindsay go ahead and play this for us. We are from many places and we have many traditions. We gather around the piano and sing while eating rum cake with eggnog. We are from many places and we have many traditions. We gather around the piano and sing while eating rum cake with eggnog. We are from many places and we have many traditions. We are from many places and we have many traditions. We are from many places. And I encourage you while you're in your space to think about, what do you like to do during the holidays? What do you eat or drink during the holidays? And thinking about plugging that into the song as well. So there's spaces for a lot of creativity in using interventions. The thing that I like about it, it also gives us an opportunity to present new music to our older adults with dementia. Yes, it is great to do music from their 20s and younger years, but they can also still learn new music activities and find ways to express themselves in music as well. So I am going to invite our next presenter, my colleague, Amy, to introduce herself. She's also going to be sharing some theoretical frameworks as well as the work that she does in Canada.
Thank you so much, Melita. Loved hearing that beautiful music. It got me grooving. So I'll tell you a little bit about myself and then bridge into my talk. So my name's Amy Clements Cortez. I'm an associate professor in the Faculty of Music and Health Sciences at the University of Toronto. And I also teach at Wilfrid Laurier University in the music therapy program. They're very different programs. One at Toronto is focused in neurologic music therapy, and at Laurier, we're focused in music psychotherapy. And I've been really privileged to work with older adults for my career, really, and specializing in dementia as well as palliative care. And I've also been a personal caregiver for my mom who had dementia. So I bring along some lived experience, but I really believe in trying to understand more from the lived experience of persons with dementia. Next slide, please. So just so that we have a little bit of background information about an aging population. So here in Canada, about 19% of Canadians are 65 plus, and by 2046, we estimate that 85 plus uh, group will be 2.5 million. If we look at some statistics, according to Alzheimer's Disease International, there are 55 million people living with dementia around the world. And so there's definitely a call from our Ontario Long-Term Healthcare Association, for example, among other calls, to develop treatment modalities that are going to maintain and support individuals at the places where they're at. And that we really need to pay attention, specifically looking in Canada at locations of care and really supporting caregivers more robustly, because that's not happening to the degree that it needs to. Next slide. So I encourage you to just look at these images on the screen for a minute. And what are they saying to you? To me, it's about who is the person I'm supporting, right? So we have medical charts and we get told what people's diagnoses are. And that can be helpful information, but I really don't like to see people in that framework. I like to learn about the person from the person. Just because someone is diagnosed with a dementia does not mean that perhaps memory is one of the issues that is impacting their well-being. So I really try to take my cues from the persons that I'm working with, and it challenges me always to be thinking about my assumptions and my biases because they can sometimes creep in when we've been working in a particular area for a long time, right? We start assuming things. And so we must always be cautious not to do that, but to come with fresh intentions in the work that we do each day. Next slide, please. So I believe at the heart of all music therapy work is relationship. It's about the relationship that I have with the music, the relationship that the client has with the music, and then the relationship that we create that is also with the music. And I also believe that it's very essential that we come to the practice with a sense of cultural humility so that we come prepared to understand the perspective from the person that we're serving. So to understand how they perceive music, health, and wellness, and to come from a place of diminishing any power differentials and really trying to appreciate how best I can support this other person, right? So it's coming from a place of understanding and trying to appreciate another's perspective as what's driving the therapeutic process. Next slide, please. So I believe that when we work in aging, we need to consider an intersectional approach to aging. And I've just put a couple quotes up there for us to think about. An intersectional approach strengthens our ability to identify effective avenues for intervention and strategies and interventions that strive towards health equity. A lot of times, it can become easy, right? We've worked in an area for a long time and we have interventions and we think, okay, well, I'll do that. But essentially, what is important is that we're always tailoring our clinical interventions to be responsive and supportive of what the person needs and not trying to apply everything to a specific demographic just because they are older adults. So not treating people as one large homogenous group. So it really means that we're giving us a more comprehensive understanding of aging related needs and finding out what needs are not met so that we can perhaps make a dent in supporting those. Next slide, please. So I think that brings us to just, I wanted to put up there, I'm sure many of you are aware of this, but just so that we're all on the same page about equity-oriented healthcare. So this is equity-oriented healthcare aims to reduce the negative effects of multiple intersecting forms of racism, discrimination and stigma, structural inequalities and structural violence, the frequent mismatches of the usual care of approaches, right, and to actually what people need that are impacted by health and social inequalities. Very passionate about trying to raise some of the systemic issues that we unfortunately still have and are still prevalent in the music therapy literature and research, where, for example, there's a lot of voices that are not present in those research studies. And then sometimes people are using that as evidence to support how they're working. And that's important to be using evidence, but at the same time, we must be critically aware that that's not representative oftentimes of a lot of the people that we're actually working with. In Canada, music therapy is not funded. So people that obtain or have access to music therapy are often people that have more power and privilege. There are people that are in organized facilities where music therapy might be potentially an option. And so I'm really working hard to try to bring music therapy to spaces where it has not been, right? And trying to include more individuals from different backgrounds. Next slide, please. So this slide here, music is everywhere. It's part of all of our lives, really, if we think about it. And just last year, a group of international colleagues and I got together and wrote about systemic issues impacting music therapy as well as music therapy education. And so that the heading on your slide is just a subheading from our article, because we believe that everyone has the right to participate in musical opportunities. Sometimes when we work with older adults, we're doing a good job. There's an example there of the Intergenerational Jamboree, which is a program here in Canada. And sometimes we're not doing so great, right? When we put headphones on a person that has dementia and leave them isolated to listen to some music. If we do a simple Google Scholar search of music therapy or music-based interventions rather and aging, we get like 35,000 hits for the last 10 years. If we refine that and we do music therapy and aging and music-based interventions and dementia, we get, about 1,300 hits. And so there is a lot of good research out there, but there's also a considerable number of gaps. Next slide, please. So look at the headlines here. Music is magical in Harvard Business Review. Have you had your dose of music therapy today? I heard that on a radio station here. Nurse implemented music therapy to reduce anxiety in community dwelling individuals. So take a moment. What are those statements saying to you? If we think about it, what happens often is that when we talk about music and we talk about health, everything gets lumped together as music therapy. And that unfortunately is not helpful, right? Because there is great value, I believe, in all of the experiences. I love going to a concert and there's value in that, as well as there's value in music therapy. So this is part of the problem that clinicians, the public, all kinds of people lump everything together as music therapy. So we also have to get better at talking about and differentiating between the different experiences. Next slide. This lack of definition, distinction, and correct terminology has really resulted in this diluted value of music therapy. And we also often don't describe the music we're using or give specifics about the intervention. We don't use music reporting guidelines. And unfortunately, that means that a lot of times replication or implications from the research are sometimes not there because it's not exactly clear what music was used or how it actually impacted change if change happened. So with that, I'm going to bridge into, I just wanted to get us on the same page thinking about that, and we'll go to my next slide. I'm going to talk to you a little bit about some of my own research that I think is helping to advance how we're working in these spaces. So at the onset of my initial investigation, looking at choral singing, there actually was limited research, and that really has expanded, which is fantastic. So I undertook a multi-phase mixed method study on singing for health and wellness that assessed participants engaging in a weekly choral program that was offered by a music therapist for 16 weeks. And there were 3 phases of this. In phase 1, it was participants in adult day program attending with mild dementia. Phase 2 was persons in long-term care with moderate dementia. And phase 3 was persons in long-term care with moderate dementia attending with a significant other. So a personal caregiver, a spouse, a child, for example. Each phase was looking at the impact of singing on various parameters of health and wellness outlined by a model by Hetler. All phases involved an intake survey to gather relevant background information. And phases 2 and 3 were co-designed with participants to get a better appreciation of what kind of test outcomes we should be using and about the specific music intervention, for example. We also surveyed everyone at the beginning to get relevant background information and to assess musical preferences, which was key. Pre and post tests were carried out in the 3 phases. In phase 1, they were larger test batteries, things like the PANAS, the positive and negative affect schedule, looking at social isolation, quality of life. In phases 2 and 3, we became more focused and narrow after the co-design, which I think improved the study design. And we were looking at things like mood, energy, happiness, pain, and anxiety. And so we had researcher observation at all of the stages. And in phase 3, we recorded the sessions on 2 cameras, and then I randomized the clips, and independent research assistants were noting what it was that they were seeing in those particular clips. And that was, to really try to increase the reliability of our results. The collage that you see on the screen is just an example of some of the studies that were published in the area, and also some of the news media that we received. At the end of each at the end of each phase, rather, participants were interviewed, and then they also performed in a large concert in the atrium of the facility. We'll go to the next slide to see some of the research results. So from phase 1, we have foster friendship and companionship, happiness, uplifting and meaningful feelings, reduced anxiety, and enhancing spontaneous fun. In phase 2, we have statistically significant results for 4 out of the 5 parameters. They were increases in mood, energy, and happiness, and a decrease in pain. And in phase 3, we have statistically significant results for the 3 parameters, increases in pain and reductions in pain. Goodness, we wouldn't want increases, and increases in energy and mood. These studies were funded from the Social Sciences Health Research Council, and they were part of a large grant, close to $2.5 million, which supported multiple small studies like this, which were looking at various parameters of singing, and I was in my own tiny little pocket of singing for health. I continue to be involved with research and singing, and I'm part of another SSHRC grant for close to $2.5 million, which looks at benefits of singing for various communication disorders. And I'm involved in a very little pocket, which is looking at that with dementia care. And I'd like to go to the next slide. You could play that sound clip for us, Lindsay. So that is some participants in the GLEE study. We got together, I applied for a small grant, and we recorded a number of tracks that we sang as sing-alongs, so that others could use that to sing along. And then I also recorded instrumental tracks. So it's a resource that caregivers can use if they want to lead a sing-along, but don't necessarily feel they have the skills to do that. So I'm really passionate about mobilizing research. We can't just do research, we have to do something with it, or what's the point? So I believed in creating this, and it was super fun to do too, if you can imagine. And then I was working at Baycrest Center at the time, and there really was a lack of cultural resources, and there was a large Jewish population there. So I worked with the therapeutic recreation staff and taught them some Jewish music, so Hebrew and Yiddish music, and we recorded a sing-along as well, audio and visual component to that. But then I wanted to better understand, am I really creating these resources to the best ability that I could be? And so I embarked on a small pilot study called Sing Along of the 1930s, where we were looking at the different technical aspects of creating sing-alongs, along with many other parameters. And that has sparked the creation of a whole set of sing-along resources that are used by and created by the Room 217 Foundation, known as Pathways. I'll go to the next slide, please. I'm going to shift gears totally now and tell you about a really different way that I work in dementia care. This is multisensory gamma stimulation in Alzheimer's. So coherent 40 hertz neural oscillation is a fundamental frequency of intrabrain communication and is a covariate of cognition. And that gamma activity is often depleted in persons that have Alzheimer's disease. So in this crossover AB pilot study, what we were looking at was using 40 hertz applied to persons with Alzheimer's at 3 stages compared to visual stimulation. So they attended sessions over a 3-week period. They had 6 sessions of the gamma stimulation and 6 sessions of the visual stimulation. And we used the St. Louis University mental status exam. That's the chart just in the top left corner of your slide. And what we found was that after each application of this sensory stimulation, that cognition scores actually increased by 0.05, which is very significant. And so they did not change or even drop slightly in the visual stimulation. In the qualitative data also supports this through sharing that there was improved clarity, cognition, and alertness of surroundings. So following this, we decided to extend and look at community dwelling older adults. And so we had them use a device that delivers sensory stimulation that can be used in the home. And we visited them at 6 months, 12 months, and 18 months. And they were using the device 5 times a week for 30 minutes. And what we found was that for several people, cognition scores remained the same over that time period. So they're really promising results, and we just really need to do more research in that area for sure. This study was funded by a grant that came through the Penny and Manford Research Institute at Wilfrid Laurier University. I'll go to the next slide, please. So right now I'm passionate about assessment for older adults. So in, I guess, late 2019 or so, I began working on an assessment tool with some colleagues. And so we created a music therapy assessment for older adults and embarked on a pilot study where we asked music therapists working with older adults in Canada and the US to utilize the tool. And then we sought their feedback. After that point, we revised the tool, and that has since been published. But at this point now, I want to make the tool much more person-centered and to see if it's relevant in context outside of North America. So I'm working with a couple of colleagues in this next phase of study. So right now in phase 1, what we've done is we had focus groups with music therapists, allied healthcare professionals, older adults, because this is a participatory action design. So we're getting all of their input. And then we have revised the form through almost like a Delphi approach where we've kind of revised and we've gone back to that group of people to ask for their input so that we are coming to the consensus at this point on the tool, which in phase 2, we will then ask music therapists to be using and then invite feedback from older adults that experienced being assessed with the tool and music therapists on its utility. So we're just in phase 1 right now of that study where we're kind of analyzing all of the data. But I'm really passionate about that because there aren't a lot of music therapy assessments specific for older adults. And we're really hoping that this one will become more person-centered and identity first, language, for example. Next slide, please. I'm so privileged to be a part of this group. I just wanted to tell everybody about us. This is through this International Association for Music and Medicine. It's a special interest group that is based on advocating for the use of music and music therapy interventions in the context of dementia. But together, we have put out a special edition of the Music and Medicine Journal, which is focused on working with older adults with dementia. There's a section there on telehealth as well. And then we also were guest editors of 2 editions of Frontiers. And we continue to look for opportunities to disseminate our work, talk about educating caregivers and offering opportunities to help mobilize caregivers in using music-based interventions as well. Thank you. And I'll just go to the next slide. So I think I've done a lot of talking and I'm going to wrap up very shortly. I wanted to leave you with some thoughts moving forward. So in 2023, Dr. Edwards and colleagues wrote this wonderful paper, which talks about a toolkit, right? A music-based intervention toolkit is what maybe is going to help us move forward in terms of music therapy research. And so this toolkit calls for research to be co-designed with older adults. It calls for us to start looking at the mechanisms of change, right? So it goes back to what I talked about at the beginning, that there is some good research, but what's lacking is this mechanistic perspective of response to music that we need. And so the thinking is that there needs to be more randomized controlled trials to assess music therapy intervention. So be very specific about the intervention that you're using, the target population, the strategy, for example. And I'm very much not a like protocol person because I feel like, oh, then we're not being person-centered. But honestly, I believe there is a way to make them more person-centered and to really be responsive. So I am, sometimes I grapple with that, but I do believe there are ways of kind of joining the two together. And I'm very much a mixed method researcher and believe in all the different research methods to help us get a better understanding of working with older adults with dementia. So there's a QR code there of references, and you can always email me if there's references that you would like from the presentation. And thank you so much for your attention. I'm going to turn it to my wonderful colleague, Etta, to take it away for us.
Hi, right, so I'm Etta, and before I begin proper, we would like to invite all of you listening in today to put in your questions in the Q&A throughout today's webinar, and we will answer them, okay? So just to give a little bit of background about me, I'm a registered music therapist from Singapore. I'm currently teaching music therapy at the LaSalle College of the Arts, and my work with older adults mainly focus with adults with dementia in an acute hospital in Singapore, and I continue to do some work in palliative care. So I received my music therapy training from Australia, and I had to make some adaptations when I returned home to work in Singapore. And I thought it would be interesting to hear some of these perspectives. And then you may also want to think about how to adapt your practices when working with people from a different culture. So next slide, please. So, and you can just get yeah, and next as well. So a little bit of background about my home country, Singapore. Singapore is a city-state in Southeast Asia. It is quite a small country, about half the size of Rhode Island, with an area of only 734 square kilometers. That means that's about maximum of 50 minutes if you drive from one end of the country to the other. And despite our small size, it is really one of the most densely populated countries in the world with 6 million people. So that makes it about 200 times as dense as the United States. Next slide, please. We consider ourselves a multiracial, multicultural, and multi-religious society. Most of our ancestors were immigrants who came from different parts of southern China, Malaysia, Indonesia, and India. So currently, the demographics of Singapore consists of ethnic Chinese, Malay, and Indian. Collectively, we make up about 98% of our citizen population. And while English is our official working language and the lingua franca, the older generation will speak different dialects within their own ethnic groups. Next slide. About 1 in 5 in our population are above the age of 65 years old, and this number is increasing rapidly. And in 5 years' time, it would reach 1 in 4. So that's quite an alarming number, right? Average life expectancy for men is about 81 years old, while average life expectancy for women is 86 years old. Next slide. So a little bit of background about Singapore's perspectives. We are a country with both Western and Asian influences. We also value pragmatism. So there's a general public acceptance of a limited government role in areas of social welfare. So caring for the aged mostly happens at home until the family members are unable to continue to do so due to the Asian concept of filial piety. So typically the caregiving falls upon children. Some of them may be above 65 years old themselves, or hired lived-in domestic foreign workers from neighboring Southeast Asian countries, many of whom are unable to speak the language of the care recipient. Next slide. With our increasing aging population, there is also a growing emphasis by our government to help our older adults age well in place. So we have infrastructures and healthcare networks put in place, active aging centers to help seniors become more connected with each other. There's also increasing awareness to have more person-centered care and emotional support for the caregivers. Next slide. And there's also this very interesting, gentle move towards encouraging use of music and the arts with the elderly, which for my very pragmatic country is very, very new. Since traditionally the general expectation is that when we do something, it should have some social or economic value. So arts for art's sake or arts for leisure sake is typically not something that is considered. So many of my patients have told me that they had no time for the arts or music when they were younger, as these were considered frivolous activities, and so they had very, very little experience. So when we come into a music therapy session, it's very hard to expect them to start improvising or start singing, and they will feel quite restricted. Or some of them actually had a strong relationship with music when they were younger, but they had to give it up after they started their family. But interestingly, what you can see here is that there's this screenshot of a government agency's webpage where they have actually curated a list of songs that are popular in the 1950s, 1960s, etc., so that the older generation can actually access these songs for their use. So within this page, they also have a toolkit of joyful activities for seniors, and they listed music listening and playing of instruments, and even gave like step-by-step instructions on how to set up the activity so that it will be successful. So that's really quite interesting. And next slide. So you can see there's a general move towards encouraging the use of music for health. And actually, as early as 2013, more than 10 years ago, there was a clinical practice guidelines for dementia care, and it stated that music therapy was recommended to help to relieve BPSD symptoms. Yet, music therapy has not been mainstream since then. Neither are music therapy services subsidized or funded by the government, unlike our other allied health disciplines such as occupational therapy, physiotherapy, or speech therapy. But there is growing demand for music therapy and interest in using music for health in Singapore. Next slide. So in the context of music therapy in Singapore, we are a somewhat young profession, given that there was no local training program before last year. In fact, our first batch of students will only graduate next year. So currently we have about 48 professional members with the Association for Music Therapy Singapore. About 40 are practicing in Singapore, and 20 are working with older adults in a range of facilities from acute hospitals to nursing home. Most of us are trained in either Australia, the UK, or USA, and we had to adapt how we practice music therapy to the local context. All right, next. So interestingly, while we had to kind of adapt our local training to suit local practices, when we look at a study conducted with seniors living in nursing homes in Singapore in 2022, we'll notice that what makes for quality living for them may not be different from the Western paradigm, So there seems to be some universality in wanting supportive living environments, having personal control, having meaningful relationships and connectedness amongst others. So in terms of what music therapy traditionally tries to address in terms of quality of life, one's personhood, meaningful engagement and meaningful connectedness or spirituality, that is still valid in Singapore. But something interesting in addition is that a study in 2023 has revealed that seniors staying at home, there's an additional emphasis on relational harmony. So seniors tend to defer to their children to make decisions for them so as not to inconvenience their children. So in terms of that personal choice and personal control part, they may actually give up some of that autonomy. Next slide. So in terms of my own personal work with people with dementia, I ascribe to Kit Wood's model of care, which emphasizes the identity of the person with dementia, especially allowing them to engage in the healthier parts of themselves and to reinforce their healthy relationship with music, providing them comfort and warmth through the music and the connection, making the person feel included in choice making and having a sense of control. making sure that the person is meaningfully engaged through participation in music, which is an occupation itself, and also helping the person feel secure and attached in a time when they may feel more and more disoriented and anxious, especially if their attachment figures are not present. I also feel that this model is useful to consider when we are working even with adults without dementia. And while Kit Wood's model of care has been studied by music therapists in different parts of the world, there has been some considerations when applying it to the Singapore context. And I think this is often where we talk about culture sensitive music therapy practices. Next slide. So I think when we talk about the idea of comfort and building trust, language is always an important factor. And in Singapore, particularly, as I shared earlier, there's so many different diverse groups. As a music therapist working with older adults, one of the greatest challenges is in navigating this cultural and linguistic diversity. So many of our older adults, especially those above the age of 75, are mostly monolingual or only comfortable in one language. This could be Malay, one of the 6 Chinese dialects, or one of the 3 popular Indian dialects, or English. So given that bilingualism was only introduced to our education system in 1966, where English was then used to teach all subjects except mother tongue, so some of the older generation may not know English and may not speak English. And as a younger person who only speaks English and my mother tongue, Mandarin Chinese, this does pose some challenges in working with such a group of older adults. Next slide. And the other aspect that many other elderly patients may be quite tentative in expressing their choices, either because they have limited exposure to music, they're afraid of doing things wrongly, they may have respect for authority as myself, as many Asian people have. And I think in a group, they also tend to be more mindful and respectful of others. So this is where sometimes people talk about that collectivist mentality in Asian cultures. They may not want to take the limelight or explicitly state their choice. So it does take a little while for the elderly to build trust and to feel secure enough to state their preferences. So for music therapists working in more long-term settings, they may have some greater stability when they are working in groups in terms of group membership, and they probably can navigate the issue of the language better. But in acute settings where open groups are more common and group memberships are not regular, this really poses as a challenge. Right, next. So I'm going to talk about how I navigate through these issues collectively. I believe just like any music therapist who works with someone from a different culture, picking up simple phrases in different languages work. So I've learned to say, how are you? Would you like to listen to music? Do you sing, play the drum, play faster, slower in Malay, Hokkien, and Cantonese? I also learned phrases unrelated to music, but are important in our culture, such as asking if they have eaten, because food is a very big part of Asian culture, and often asking someone if they have eaten is a sign of concern and care for them. Sometimes when the adults are tentative, it's very hard to ask them to engage and play music straight away. So I usually start by playing something rhythmic that I know is familiar to them due to their age profile and also their culture. This is also music that patients can groove to and warm up to. And this warming up process is really important before we ask patients to disclose more of themselves. And I'm not even asking them to reveal big things, but even just showing how they play music is a kind of disclosure for them. I usually give them something more concrete, such as giving them songbooks in different languages to allow them to make choices. Understanding the culture and how they are inclined not to explicitly make choices mean that sometimes the choice making is so subtle. It could be them just staying on a page for a longer time without them stating obviously that they would like to listen to a song. In fact, if you actually ask them then if you would like to listen to that song, they may quickly flip the page to something else because they may be a little shy of the attention that's shown to them, and they may also feel a little bit confronted. So I would sometimes not even confirm the choice. I would just play the music straight away based on the fact that I've noticed that they've stayed and lingered on a page for a longer time. And then hope that this sets them up to feel more comfortable and at ease to have a conversation relating to the song later. Other times when I do expect them to do something, like playing an instrument, I'll give very, very specific instructions of what to do so that they will feel safe, that they're doing something right, and they won't be losing face from doing something wrong. Losing face is also another Chinese concept, right? So all these will allow our older adults to feel more free and to review themselves over time. I think the big challenge really is that when I have to do a group that is very, very racially and linguistically diverse, so I could have a group of Indian patients, Malay patients, Chinese patients who speak different dialects. We have a shared history. So this is something probably quite unique to Singapore, and this is something that I actually tap on. So there are some songs based on these shared history. Some of the Malay folk tunes that are known to 80% of the older adults who stayed in kampongs. These are like villages or community where people of different races stayed together, or campaign songs. So I mentioned how pragmatic my government is, right? So in the past, in the 1960s and 70s, they used to have a lot of campaign jingles to promote certain activities. So you're going to hear an example of this. So this is a clean up, a keep Singapore clean example. So we're just going to listen to just one clip, the first one in English.
Put waste in a bin or else it will rot and smell. Flies and other vermin will a threat to health foretell.
And they would actually create similar tunes for the jingles in Malay and also in Mandarin. So it's really interesting and very, very useful for reminiscence because this is a shared part of their identity, and we could probably use tools like this. Next. So the last part the last thing that I do when working with different diverse groups in a group setting is really unsexy, but I think an effective solution is to really streamline the groups. So if I have a very, very good group going with two Malay gentlemen discussing and singing Malay oldies, and I see care staff trying to push a Chinese dialect speaking lady to join the group, I would actually ask the care staff to hold on so that I can attend to the lady later, so that we can have more deeper and meaningful interactions with both groups, and we can truly engage them in ways to show that we value their identity and their personhood. Next slide. I think what I'm trying to get here at the end of the day is that I think it's really important to recognize the unique personhood of the older adult whom we are working with. So while the desire for meaningful connected relationships and meaningful engagement is universal, what makes the relationship truly connected comes from the understanding of the unique culture of the person, including the nuances and subtleties that come with their cultural identity and their personal history beyond linguistic differences. This includes the idea of personal control and autonomy, what personal control looks like to a Chinese Singaporean adult in Singapore. Even though, they say that they value personal control, it may look different from what, from a person who may not be brought up from the same culture. So that's, I think, important points for us to consider and ponder about when we actually work with our clients. All right, and that's all I have for today. Thank you. I'm going to hand over the time to Lindsay.
Hello, everyone. You've heard my name mentioned quite a bit throughout this webinar. My name is Dr. Lindsay Wilhelm, and I'm an associate professor at Colorado State University. And I am so excited to be speaking with you today, and having listened to my colleagues, I just love our collaborations, and I love how much I have learned from working with each of them, and we will continue to learn from each other. I have always wanted to work with older adults, even before becoming a music therapist. And as a music therapist, I've worked with older adults in medical, residential, community, and end-of-life settings. And as an educator, I like to teach about working with older adults, and I'm really invested in enhancing student education surrounding aging. And I'm passionate about exploring how music and music-based approaches can support aging adults with a focus on accessibility. So let me share a little bit about aging in Colorado. So I have on this slide a map of the United States indicating where I am in northern Colorado, and a picture of the foothills where I live. And in Colorado, we actually have 259 music therapists, and that is not enough music therapists to consider all of our aging population, which is the fastest growing demographic in the state. So currently 1 in 7 Coloradoans are over 65, and this actually will increase to 1 in 5 by 2035. Older adults in Colorado are not as racially and ethnically diverse as, say, what Etna is describing, or as other parts in the United States as well. However, it is anticipated that Colorado will follow a national trend, and it's estimated by 2050, persons of color over the age of 65 will make up nearly 42% of the older adults in the state. So the lack of racial and ethnic diversity does not actually mean that the older adults in Colorado are not diverse. And I think you've heard this repeated throughout the webinar from my colleagues as well, that there are many facets of social identity that really influence the therapeutic relationship, as well as perspectives on music and music therapy. So for instance, within our state, we have geographic differences that influence access to, as well as acceptance of, community health initiatives. In general, aging adults in Colorado do desire to age at home, which is similar to what you've heard from my other presenters here today. But so there is a focus on community-based interventions and support for care partners. As you have heard those other panelists discuss, music therapists in Colorado are board certified, but music therapy is not a regulated or protected profession within Colorado. And I think that's important to acknowledge, because we do have limited funding opportunities, or at least not as many funding opportunities as some of our other colleagues in other disciplines may have. I have had the opportunity of partnering with several different community organizations that support older adults in Colorado. And 2 of these I'm going to speak about a little bit more in detail, Volunteers of America and the Columbine Center for Healthy Aging. So let me give you a little more information here. What I want to focus on here is music therapists training others. That's where some of my work has focused. We know from numerous research studies, I've given you a couple more recent publications, that music therapists are often training other non-music therapists, so caregivers, nurses, social workers, chaplains, family members, and community members, on strategies for interacting with older adults who have dementia in music. There's also, coming out of some of my other colleagues around the world, this idea of indirect music therapy in dementia care, where music therapists train caregivers, professional or informal caregivers, to actually be implementing music techniques and music experiences and interventions. So I'm going to tell you about a couple different programs, research studies that I've been involved with regarding music companionship. So this is not music therapy, but it is a music-based intervention focused on improving health outcomes and social outcomes for older adults in the community. One is focused on training volunteers, and then another was focused on training students, music therapy students specifically, to form music connection. And then I hope to give you a couple examples of kind of what we're facing with educating future music therapists in this area too. So I want to share a bit about training volunteers to use music in companionship care visits with older adults in the community. First of all, I want to let you know that this is not where I originally imagined my research starting. I had a focus group with dementia care partners in Northern Colorado. And I was like, great, what can we do? They started using music at home as part of another program they were a part of, and they spontaneously started doing this. And I was like, great, as a music therapist, we can really use that, and you can be using music in the home. And I sat down and I was listening, and everyone around the table was like, we have a lot on our plates. Music right now is not something we feel like we can engage in, but how about you get a volunteer? And so I had to sit back and say, well, I listened, I heard, And now I need to try and come up with a response that is incorporating that feedback. And so I partnered with Volunteers of America and their Caring Companion program, which matches volunteers with older adults in the community for weekly companionship visits. And the three main components of companionship care are connection, emotional support, and socialization. And as a music therapist, this was really exciting to me because I know that music can be used to support all three of these areas. And so our vision for this project was that the volunteer and the program participant would be sharing in a music experience together during their weekly visit, which really does relate to this idea of music companionship, where we have a synchronization of the music between two people, a musical companionship. So within this structure, I knew that there was a need to individualize the music, which relates to what all of my co-presenters have been talking about earlier. And I'll share a little bit more about how that played out in this project. But we wanted to structure multiple ways to engage with music, which included listening and reminiscing. It included moving with music and singing. And as well, we needed to ensure volunteer autonomy, because me coming in from the university and saying, hey, volunteers, you've been able to do whatever you wanted to do with your program participants, and now I want you to completely change and shift. I had to really be careful in my approach and make it so there were a lot of different ways that people could choose to engage with music. So overall, we had trainings for these volunteers, and with materials to support the visits, volunteers were given that freedom to use those materials in any way they were comfortable with. So they had a songbook with lyrics and discussion prompts and discussion guides and suggestions for movements. They had a playlist that was curated based on an interview with the community member, the older adult community member. And so really the volunteers were given all of these resources and then could use them as they felt was best in partnership with that participant. And we found that the participants preferred a lot of different ways of engaging with music. And even some of the volunteers expanded to new ideas, such as watching music videos together as a form of a companionship activity. So thinking about these volunteers who participated in this project, they ranged in age from 28 to 80 years old. So we have a clear, wide range in generations, and they all were matched with older adults. And so it was quite possible that we would have intergenerational type interactions as well. And so that was a really key thing for me to be focused on. We had also a wide range of prior music experiences in these volunteers. So one volunteer expressed not really liking music, but since the community participant, that older adult that they were partnered with, really enjoyed music, they said, hey, you know, I'll do it. My participant wants to do this program, we'll do it. And so they did. And then we had another volunteer who had worked as a DJ and had introduced the Beatles at a live concert. So we had a very wide range, which meant that I had to really individualize the support materials for the volunteers and the trainings for the volunteers, as well as individualizing the music. So let's talk a little bit more about that music piece, because it really became key in this program. So our participants ranged in age from 73 to 99 years old. And we had companionship materials that were created for each program participant. We had music therapists who spoke with each participant to begin identifying a musical profile that could be used with music companionship visits. And we found that participants in this project had very diverse musical backgrounds and preferences, even though they all were in the same geographic location. It was all in Northern Colorado. So for instance, we had one participant with a migration history where they were born outside of the US. They were fluent in French and Arabic. And by using resources such as keyboard language and Google Translation and international Amazon sites and a little detective work, we were able to identify songs that were preferred by this participant and that were more meaningful to create translations to support discussions for the song sheets. So on the slide here, I have an example of the top keyboard on the right is a Hebrew keyboard. The second one is Arabic, and my computer is still set up like this. So sometimes I accidentally switch my keyboard. And so that's always an adventure when I'm trying to type in a different language. We also were using Spotify and Facebook to identify songs that our participants liked because they were using Spotify and Facebook to listen to songs. And so it was really key to then be able to take these screenshots that volunteers had sent me and said, hey, she just brought up this song today. Can you help with finding it? And so that really helped. If we think about for this particular participant and their culture of heritage, they had fled their country of origin. They were a young adult in Europe and they immigrated to the US. So we knew that. If we think about culture of religion, they practiced a minoritized religion in their origin country as well as in the United States. They immigrated twice. They were born in the 1940s, but based on all the information I already gave you, that 1940s number isn't going to give us a whole lot to go on music-wise. If we talk about where they were from, they were in Egypt, France, Illinois, and Colorado. So we have a lot of different cultures going on there and mixing. And if we talk about culture of identity, for this participant, their view on the role and value of music was very different. So if they wanted to visit with someone, they didn't want a whole lot of rambunctious music on. They wanted quiet music in the background. But if they wanted to dance, then they really wanted this music. So there was a lot of coaching of that volunteer too on how to be responsive to the ways that this older adult was wanting to interact. In contrast, we had another participant who was born in Europe during the same generation, born in the 1940s, also from a minoritized religion and had immigrated to the US as a child. But so their personal identity and music preferences were very different, even though we saw similarities in age and their countries of origin, as well as immigrating to the United States. So it was a fun project. So let me tell you a little bit about what happened as outcomes from this. What did we find? So after a minimum of 5 volunteer-led music companionship visits, volunteers, care partners, and older adult participants reported that music companionship visits assisted them in building relationships and interpersonal interactions. Music stimulated new conversations for conversation. In pre and post measures, we saw a decrease in isolation and increased feelings of social connection in the participants. And we also found that this type of music companionship program was really enjoyable for the volunteers, the participants, and their care partners. And so we also had found that for some of our community members, there really was a rediscovery of the personal importance of music. All of our participants were given a small stipend in response to their involvement in music. And one of our volunteers actually partnered with her community member. The community member had a ton of CDs, but had no way to play them. And so they pooled their funds and were able to purchase a CD player that they then could use during their music companionship visits. And they hadn't even explored that area of their relationship or getting to know each other regarding music. So I've got an eye on the time here. I want to make sure I keep moving through. I also have the Thrive Project, which was partnering music therapy students with community members. And this was in response to the COVID-19 supports that we put in place in Fort Collins here. And we were really wanting to focus on music connection. And so each of these visits were very participant driven in focus. They happened over the phone or in virtual video meetings. And so the types of music engagement that these music therapy students were supporting with these community members really ranged from creating music playlists over the phone, saying, device, add this to the playlist, to listening and discussing music together, to active music making, pulling out instruments and playing for one another. And what we found is that there were really great benefits for both the students and the community members. For the community members, their comfort level and openness increased over time. The more that they met with these students, the more they would share about their memories and their emotions associated with music. We had one participant with a memory impairment who actually would share the same story about a song every week, but a little bit more detail and a little bit more nuance and context was added to the story with each meeting. So that it wasn't even the same thing happening over and over, but it was really building on and expanding their relationship through this story. We had one participant who told the student that these meetings really changed her life. This was a participant who was experiencing challenges with feeling lonely, and the student companion helped them to create these song lists that she could listen to throughout the week, focused on different themes. And so at the very end of this program, the participant asked the student if she would put together a series of playlists for her to have a dinner party. And so she hosted a dinner party with themed music for her friends and her family that were in the area. And it just was really neat to see that blossoming and recognition of how music could help her in her weekly experiences and lived experiences. For the music therapy students, the student companions, they all identified, that increased value of interpersonal skills. They saw what we had been talking about in our classes at CSU, and a value of how those interpersonal skills really created a stronger connection with the community members they were paired with. And they directed conversations by saying, like, tell me about your relationship with this song. Why is this song special to you? And really use the music as a foundation to build conversations, which made it so they connected really fast, which can be something that's really hard when you've never met someone in person. We also, an outcome that we weren't really expecting was one of our students reported that they experienced an increased sense of community. The student was new to the area and had moved here for school and felt a greater connection through building these relationships, and continued to meet with the participant outside of the research study until they finished their degree here at CSU. And so that was really neat to see that connection that was made. So I want to give you some considerations here if you are wanting to coordinate a music companionship program. Individualization of the music is really key. And a music therapist is really uniquely qualified to help support in that. But I think that there are also so many resources available that even just having a conversation about what music, for someone who may not have as much musical training, and using tools like Spotify and YouTube can make this really accessible. And then matching the type of music engagement with the desired outcome. So for some folks, more of a passive listening and talking about and experiencing of emotions that came up through the music and kind of processing those was more of what they were looking for. And other folks were just like, no, I want to move with music. I want to create, found sounds to create instruments, or I want to actually share music with other people. And so that music and the type of engagement really varied. We always have to encourage autonomy in the companion, whoever that is, whether that's a family member, a friend, or a paid staff or a volunteer staff. And then a music therapist really is uniquely qualified to help facilitate training and support for that companion to possibly be engaging in music with someone else in a way that they've never engaged with music before. In my last couple minutes here, I want to also share some examples from my students from this last semester. They did give me permission to share these examples. And the reason I want to share this with you is because I think it's so important for us to continue to focus on, especially where I'm located in Northern Colorado. I have a lot of students who are coming into our program who have little to no experience interacting with older adults outside of the music therapy program. And many of them may not have had opportunities to interact with people who are different than them. And so I really try to incorporate into our education here opportunities to expand in those areas. On the slide here, you'll see actually an example of a bilingual songwriting TME. It wasn't planned to be bilingual. This practicum student was starting to facilitate a kind of a fill-in-the-blank songwriting experience using Annie's song by John Denver. And it was a group that we had worked with. It was at a facility that does accept Medicare funding. And so we see folks from a lower socioeconomic status type of background at this facility who don't have many friends and families to visit. And so we had this group and we were doing this TME of talking about spring and what we sense in the spring and things that we enjoy when we are the sensory that we enjoy. And as she was facilitating this, she had one client with dementia who we knew had a background in spoke both Spanish and English, but we'd never interacted with her using Spanish before. And so she wasn't answering the question in English. And so my student actually just in the moment flipped and said, provided the question in Spanish, and we got an answer. And it's interesting because then just a couple minutes later, we had a new resident that we had never met before come into the group. And he was very hesitant to come into the group. And was telling us, no, I don't speak English. Spanish, Espanol. And so because of the way that this was structured and using resources like Google Translate, we were able to include this individual who reported not speaking English into our songwriting. And so we put those Spanish responses into that and sang through it. And the group overall just embraced this and said, oh my gosh, it would be amazing to hear this in Spanish. And so my student came back and we did it the next week in English. And then we did it in Spanish as well. And it was amazing to see how that really brought the group together. The folks who didn't speak Spanish wanted to know more. The folks who did speak Spanish were then matching up what was being sung in Spanish and how did that match up in English. And it really was a connection for the group. The same facility, I bring students to engage with these groups. And what we see is students who were very nervous before leading this group in a supported environment come away after doing one song and are like, oh my gosh, I saw reactions and we interacted and it was wonderful. And we see students who completely shift and change their focus. And I want to make sure that we have time for the panelists. But I think we can also think about sharing culture coming from the music therapist side of things too, and the student or the companion or the volunteer side of things, and thinking of this as a cultural exchange and what benefits there are there too in learning about different cultures and people different than ours. And so this was a student from China who brought in a Chinese folk song, very purposefully selected to support what we were doing in a group with individuals with dementia. And these individuals just embraced this opportunity and started asking the student more and wanted to just learn more. So I know I am out of time. Here are my references. We now do have some time for questions for our panelists today. And I think Melita will be helping to moderate this section as well.
Yes, so if you have any questions or comments, we'd love for you to drop them in the Q&A portion on your end, and then we can answer them live amongst the panelists. So go ahead and take a few minutes. We have 7 minutes together, so we'd love to have you do that. We'll also have a QR code on the next slide to ask you to consider joining the network. We want more colleagues who are interested in music and dementia. The network is there on the screen. Just put your phone up to that QR code and it'll take you directly to our page. And again, we'll take questions in the Q&A. And I know I had so much fun listening to each of the presenters. I always learn so much when getting to be in space together with these lovely humans. So drop your things in the Q&A and we'd love to hear more. All right, we have one from Jess Rushing. Hey, Jess. Okay. Can you speak to your thoughts on the role of learning in older adults' care, them learning, much like Lindsay mentioned, how they enjoyed learning new cultural information? Thanks. Does anyone want to take that first on learning? I am also happy to jump. I'll jump and then, or
I was gonna
Lindsay,
say,
you.
talk about your museum.
Oh, yeah, yeah, yeah.
Yeah,
So,
that would be great.
yeah, I spent a couple years working with the Musical Instrument Museum here in Arizona. And they were already doing a dementia project at the museum. And we were working on individuals with dementia having museum content. And the museum goes around galleries around the world. So they're going to be introduced to new music and new concepts. And then I came in to do the music therapy portion. And what I had learned years ago from an intergenerational rock band was that older adults with dementia can learn new music and that they can learn popular music if you teach it to them with repetition. And we had an older adult in that choir who oftentimes his favorite song, he was a politician. He used this song during his campaign, was This Land Is Your Land. But the most amazing thing was when he was able to sing back Bruno Mars and other music that we were learning with the same gusto that this land is your land. So this idea that we don't have to just use older adults' preference, we can introduce them to new things, and through repetition and using creative music interventions, it gets in the brain, it gets encoded. So I want to make sure I see a question coming for Etta that she can answer that question. Go for it, Etta.
Right. Thanks for your question. So I don't really know what my students think, but I think people have been waiting for the program in Singapore for a long time. So I think my first batch of students, they some of them waited for 10 years because they couldn't afford to go overseas and study. So I think this is very much needed. I myself had a little bit of an epiphany when I was actually having class with them, the first musicianship class, and then because people were just supposed to bring a song that they were familiar with into the class, something that meant something to them, and I realized that I recognized every one of these songs, and it was a very different experience for me when I was studying overseas. I was in a place where every single song was not familiar to me, even though I was comfortable with English, but because I was in a different country. So I just realized that it might be much easier for my students to work with our clients because there are some nuances that they don't even need to second guess and think about, and it's just part of them. So I think that's, I think, the benefit of being able to be training in a country that is, that you're going to be working with the population that you will eventually work with.
Thank you, Etta. And I also wanted to invite anyone else who wanted to answer questions about music learning and learning in learning new things for individuals with dementia, if they had anything else. And also keep those questions coming. And this video of this webinar will be on the YouTube page for the Dementia Research Network.
And while we don't have any other questions, if I can speak to the learning component too, I mean, we have a study, it's really old at this point, that I think was Dr. Alicia Ann Clare, who presented individuals with dementia rhythmic exercises with drumming over a series of several sessions. And we actually saw where there was motor memory across those sessions. Please, panelists, speak and jump in here if I'm not remembering this correctly. But we actually saw that there was learning. It may not be declarative knowledge that, like, that you know, but they were actually seeing growth and change. And we've seen this in Dr. Betsy King's research too on small group music therapy, where from week to week, if you have this repetition, when it is expected what is happening, you can start to change and build on, and there is learning that occurs even for individuals with dementia, and you will start to see relationships develop. So social engagement shifts over time through music, which, if we think about our traditional idea of what dementia is, which I also would challenge, is very narrow and is not person-centered, that is very different than the way that we think about and conceptualize dementia. All right. Jess, we have another question here in the chat if there's anyone who'd like to speak to that regarding the use of technology and the role of technology in the rising generations of older adults.
One thing I'll say is just continued empowerment. And again, that teaching component of technology. Um, and music is something that's so rewarding for people. That is a hook to allow them to come into more technology spaces. And then the things that get open up in their lives when they're getting to use it. So that would be for me is encouraging technology in any form and empowering older adults as consumers of technology to be able to use ways to connect with music. Amy, what are you going to say?
Just going to chime in just about telehealth, and I think there's a lot of opportunity. There's a lot of challenge, right? Because people don't have equal access to telehealth, but I think there's a lot of opportunity there. I'd also like to see more, go into virtual reality, and like there's just so much opportunity. I think sometimes music therapists might be like we're just so busy doing other things we don't necessarily have time. So I think collaborating with tech experts and biz tech can really help us move that area forward. So I'm pretty excited about what the opportunities are.
Thank you all so much. Lindsay and Etta, did you have anything that you wanted to share before we go? Okay, well, we thank everyone for being present with us. I'm going to just drop a couple things in the chat. I'm doing it on the answering Jess Rushing's last question, so you can see spaces for joining the network, keeping up. Our videos of this webinar will be posted to the MDRN website. So we encourage you to do that. And from our presenters and myself, we thank you for taking an hour and a half of your Friday to be with us. And we hope to see you all soon. Bye.